Most people believe that sleep is simply the time when nothing is happening. The day ends, the lights go off, the body rests, and by morning everything resets. I used to think of sleep that way too, until I started reviewing the overnight data of patients who had experienced sudden cardiac events. Men and women who seemed perfectly healthy during the day. No obvious warning signs, no dramatic symptoms. And then, in the early hours of the morning, something went quietly and catastrophically wrong. Here is what almost no one tells you. The hours you spend asleep are not a pause in your cardiovascular life. They are one of the most demanding periods your heart will experience in any 24-hour stretch. And one common sleep habit, a habit that nearly half of adults over 50 engage in without a second thought, may be quietly increasing the risk of serious heart events. Today, I am going to walk you through exactly what that habit is, why it matters so much as the body ages, and what the evidence actually shows about the connection between disrupted sleep and cardiovascular strain. This is not a video designed to frighten anyone. Sleep problems are extraordinarily common, and most of them are manageable once they are understood. But most people have never been told what is actually happening inside their chest during the night, and that gap in information is worth closing. Let me ask a simple question first. When you go to bed, what is the last thing you do? For many people, it involves a phone, a quick check of messages, a short scroll, a few minutes of news or social media. The brain receives a final burst of bright light, emotional stimulation, and mental activity. Then the device is set down, the light is switched off, and sleep is expected to arrive. This is one pattern. Another pattern is eating late, a snack after dinner, a full meal close to bedtime because of a busy schedule, a small indulgence in the evening that has become a nightly ritual. Still another pattern is drinking something in the evening, a glass of wine to relax, a nightcap to unwind, a warm drink that contains more caffeine than most people realize. And finally, there is the pattern that I want to focus on most closely today because it is the most common, the most underestimated, and the most consistently linked to cardiovascular strain. That pattern is poor sleep position combined with untreated snoring and interrupted breathing during the night. Before anyone dismisses this as a minor issue, let me explain what is actually happening inside the body during those interrupted breathing episodes. When breathing stops or becomes restricted during sleep, even for 10, 15, or 20 seconds at a time, oxygen levels in the blood begin to drop. The brain detects this drop and triggers a stress response. Adrenaline is released, heart rate increases, blood pressure spikes. The sleeper usually does not fully wake up. There is a brief arousal, a shift in position, a gasp or a choke, and sleep resumes. And then the pattern repeats, and repeats, and repeats. In moderate cases, this cycle can occur 15 or 20 times an hour. In severe cases, it can occur 30, 40, even 60 times an hour. Across a single night of 8 hours, that is potentially hundreds of cardiovascular stress events while the person sleeping has no idea anything is wrong. This pattern has a name: obstructive sleep apnea. And while the general public often thinks of sleep apnea as a snoring problem, cardiologists think of it as a cardiovascular problem that happens to produce snoring as a symptom. The distinction matters enormously. Research published in major cardiology journals consistently shows that untreated moderate to severe sleep apnea is independently associated with significant increases in the risk of high blood pressure, atrial fibrillation, heart attack, heart failure, and stroke. The risk is not small. In some studies, untreated severe sleep apnea is associated with a 2 to 3-fold increase in the risk of serious cardiovascular events over time. Now, here is the part that almost no one talks about publicly. The vast majority of people with obstructive sleep apnea do not know they have it. Estimates suggest that in adults over 50, more than 80% of cases are undiagnosed. The partner notices the snoring. The person waking up feels tired despite a full night in bed. Morning headaches become routine. Afternoon energy crashes become normal. And through all of this, the cardiovascular system is being stressed night after night without any direct warning. The body adapts until it cannot adapt anymore. Why does this matter so much after 60? Because the aging heart is less forgiving of repeated stress. The walls of the arteries are less elastic. The electrical conduction system of the heart is more sensitive to sudden changes in oxygen and adrenaline. The kidneys respond more slowly to fluid shifts, and the brain is more vulnerable to the subtle cumulative damage of repeated oxygen dips. What a 40-year-old body can absorb with minimal visible consequence, a 70-year-old body registers as meaningful strain. This is why conditions that develop quietly during middle age often begin producing symptoms and events in the 60s, 70s, and beyond. Let me explain how to recognize whether this pattern might apply to someone in the household. The classic signs are loud, persistent snoring, especially snoring that pauses and then resumes with a gasp or a choke. Witnessed breathing pauses reported by a partner. Waking up with a dry mouth, a sore throat, or a headache. Excessive daytime sleepiness that cannot be explained by short sleep hours. Difficulty concentrating in the afternoon. A neck circumference greater than 17 inches in men or 15.5 inches in women. A body mass index in the overweight or obese range. And interestingly, new onset or worsening high blood pressure that is difficult to control with standard medications. That last point is one that many patients are surprised to hear. Hypertension that stubbornly refuses to respond to 2 or 3 medications is a common clinical signature of underlying sleep apnea. But here is a crucial nuance. Sleep apnea can occur in people who are not overweight and who do not snore loudly. It can occur in thin women. It can occur in people whose only symptom is unexplained fatigue. And it becomes more common with age, regardless of body weight, because the muscles of the upper airway lose tone over time. This is a condition that deserves consideration in anyone over 60 who has any combination of cardiovascular disease, daytime fatigue, or high blood pressure resistant to treatment. There is also a related issue that deserves attention, and that is the sleep position itself. Sleeping flat on the back tends to worsen airway collapse in anyone prone to sleep apnea. Gravity pulls the tongue and soft tissues backward, partially obstructing the airway. For many people, simply sleeping on the side reduces the frequency of breathing interruptions dramatically. There are small positional devices, simple cushions, and even specialized T-shirts designed to discourage back sleeping. For some patients, this one adjustment reduces sleep apnea severity by half. It is not a cure, but it is a meaningful intervention that costs almost nothing to try. Now let me address another common sleep pattern that cardiologists watch closely. Very short sleep duration. Consistently sleeping fewer than 6 hours per night, not occasionally but as a steady pattern, has been linked in large studies to higher rates of coronary artery disease and stroke. The mechanism is complex, but it involves chronic elevation of inflammatory markers, disrupted regulation of blood sugar, and sustained activation of the stress hormone system. On the other end of the spectrum, consistently sleeping more than 9 hours per night, particularly when combined with daytime fatigue, can sometimes be a marker of an underlying problem such as depression, undiagnosed sleep apnea, or a thyroid issue. The sweet spot for most older adults appears to be 7 to 8 hours of high-quality, relatively uninterrupted sleep. There is one more pattern worth discussing in detail: irregular sleep timing. Going to bed at wildly different times, sleeping long on some nights and short on others, sleeping during the day and staying awake at night. The body has a master clock that regulates cardiovascular function, and when that clock is repeatedly disrupted, the cardiovascular system shows measurable strain. A study of older adults found that those with highly irregular sleep patterns had significantly higher rates of cardiovascular events compared to those with consistent sleep schedules. even when total sleep hours were the same. Consistency matters. Going to bed and waking up at roughly the same time every day is a simple, free, and underappreciated cardiovascular intervention. So what should someone actually do with this information? Let me walk through 4 concrete steps in order of importance. The first step is screening. If there is any suspicion of sleep apnea, based on snoring, witnessed breathing pauses, morning headaches, or unexplained daytime fatigue, talk to a doctor about a sleep study. Modern home sleep tests are widely available. They involve a small device worn overnight in the patient's own bed. The results are reviewed by a sleep specialist and produce a clear answer. This single step has probably prevented more cardiovascular events in older adults than any other single intervention in sleep medicine. The second step is treatment when indicated. For moderate to severe sleep apnea, continuous positive airway pressure therapy, commonly known as CPAP, remains the most effective option. The modern devices are remarkably quiet, surprisingly comfortable, and dramatically more tolerable than the equipment from even 10 years ago. For milder cases, oral appliances fitted by a dentist trained in sleep medicine can be effective. Positional therapy, weight management when relevant, and avoiding alcohol in the evening all play supporting roles. For specific anatomical cases, surgical options exist, though they are generally considered after other approaches have been tried. The third step is attention to sleep hygiene. This is a practical list, but it matters. Keep a consistent bedtime and wake time, including on weekends. Limit bright light exposure, especially from phones and screens, in the hour before bed. Keep the bedroom cool, dark, and quiet. Avoid large meals within 3 hours of bedtime. Limit alcohol within 3 hours of bedtime because alcohol, counterintuitively, worsens sleep apnea and disrupts the deepest stages of sleep. Limit caffeine after early afternoon because caffeine has a longer half-life in older adults than most people realize. These are small adjustments, but in combination, they can transform sleep quality. The fourth step is attention to the overall cardiovascular picture. Sleep is one piece of a larger system. Blood pressure control, cholesterol management, diabetes control, weight management, regular physical activity, and stress reduction all interact with sleep in important ways. Improving sleep often improves blood pressure. Improving cardiovascular fitness often improves sleep. These systems support each other, and small improvements in one area often produce meaningful improvements in others. Let me share a story that illustrates why this matters. A gentleman in his late 60s came in after experiencing an episode of atrial fibrillation, an irregular heart rhythm that had landed him in the emergency department. He had no prior cardiac diagnosis. He was only slightly overweight. He took no regular medications. On the surface, he looked like a healthy older man. His wife, during the consultation, mentioned almost as an afterthought that he snored terribly and sometimes seemed to stop breathing in the night. A home sleep study revealed severe obstructive sleep apnea with more than 40 breathing interruptions per hour. He began CPAP therapy. Within 3 months, his blood pressure had normalized without medication. Within 6 months, his atrial fibrillation episodes had stopped. A year later, he told me that he had not realized, until that point in his life, what a full, restful night of sleep actually felt like. He had been tired for so long that he had forgotten anything else was possible. His case is not unusual. It is, in fact, quite common, and it illustrates something important. The connection between sleep and cardiovascular health is not a mystery. It is not controversial. It is well documented and increasingly well understood. What is missing for most patients is simply the conversation. The question that leads to the sleep study, the referral that leads to the diagnosis, the treatment that leads to the transformation. There is one more dimension worth discussing before we close: the relationship between sleep and medication timing. Many older adults take medications for blood pressure, for cholesterol, for diabetes, for a variety of common conditions. When those medications are taken and how they interact with the sleep cycle can influence both their effectiveness and their side effects. Some blood pressure medications work better when taken in the evening because blood pressure naturally follows a rhythm, rising in the early morning hours. Certain cholesterol medications are traditionally taken at night because the body produces more cholesterol during sleep. Some diuretics, on the other hand, should generally be taken earlier in the day because taking them too late leads to repeated nighttime bathroom trips that fragment sleep and undermine the very rest the body is trying to achieve. These are not minor technical details. They are the difference between medications that work with the body's natural rhythm and medications that fight against it. If someone in the household is waking up 2, 3, or 4 times a night to use the bathroom, that pattern deserves attention. It is sometimes simply a matter of fluid intake in the evening. Sometimes it reflects the timing of a diuretic. Sometimes it is a sign of prostate issues in men or bladder changes in women. Sometimes, less obviously, it can be a symptom of sleep apnea itself. The repeated stress response during interrupted breathing signals the kidneys to produce urine, which is why many patients with untreated sleep apnea find themselves up repeatedly at night. Treating the underlying sleep issue often resolves the bathroom problem along with it. Another pattern worth mentioning is the relationship between daytime napping and nighttime sleep. A short afternoon nap, under 30 minutes, taken early in the afternoon, generally does not disrupt nighttime sleep and can actually be restorative. A long nap, over an hour, or a nap taken late in the day often pushes nighttime sleep later, reduces sleep pressure, and fragments the entire 24-hour rhythm. For older adults who struggle with nighttime sleep, the first thing worth examining is often the pattern of daytime napping. Reducing the length or timing of naps can, for some people, dramatically improve the depth and continuity of nighttime sleep. So what should someone take away from all of this? 4 simple questions worth asking a doctor at the next appointment. The first question: given my age and my cardiovascular profile, should I be screened for sleep apnea? The second question: is my current blood pressure pattern consistent with good quality sleep, or is there reason to investigate further? The third question: are any of my current medications affecting my sleep in ways that might matter? And the fourth question: what changes to my sleep environment or sleep schedule would you recommend first before we consider anything more involved? Those 4 questions can begin a conversation that genuinely changes cardiovascular outcomes. Here is the single most important point to take away from today. Sleep is not wasted time. It is not a passive state. It is one of the most active and important periods of cardiovascular recovery in the entire 24-hour cycle. What happens during those 7 or 8 hours shapes blood pressure, heart rhythm, inflammatory balance, and the subtle repair processes that keep the cardiovascular system functioning year after year. When sleep is disrupted night after night by untreated breathing problems, by chronic short duration, by irregular timing, or by a combination of all 3, the cardiovascular system pays the bill eventually, often silently, often for years, until the bill comes due in the form of a sudden event that seemed to appear out of nowhere. The good news, and this is genuinely good news, is that sleep is one of the most modifiable areas of cardiovascular health. A good sleep study, an effective treatment, a consistent schedule, a quiet bedroom, a simple shift in sleep position. These interventions are not expensive. They are not dramatic. They do not require surgery or powerful medications. And yet their cumulative effect on cardiovascular health over years is meaningful and measurable. If the information in this video has made you wonder about your own sleep or the sleep of someone you love, that wondering is worth acting on. Mention it at the next doctor's visit. Ask whether a sleep study would be appropriate. Pay attention to snoring, to breathing pauses, to morning headaches, to persistent afternoon fatigue. These are not minor annoyances. They are signals. And in older adults, signals deserve attention. Everything shared today is general health information based on published cardiovascular and sleep medicine research. Every individual's situation is different. Before making any change to sleep, medication, or treatment, please have a full conversation with your own doctor. They know your history. They know your medications. They know the context that no general discussion can capture. That conversation, careful and unhurried, is exactly where good cardiovascular care begins. Take care of yourself, pay attention to your sleep, and give your heart the rest it genuinely deserves.